Good evening, everyone. Welcome to our Pulse webinar. I see a lot of familiar names and faces on the screen from our 5 Wishes webinar. If you missed the 5 Wishes webinar, my name is Pauline Matindon Garcia. I am Livingston's Director of Care Transitions. So in my role, I help our patients and patients' family navigate their options between palliative care and hospice care. So just like our presentation, our previous presentation with 5 Wishes, I will be moderating today's presentation, and Terry Helton will be presenting. But before we begin, I'm just going to go over a few of our housekeeping notes to make sure every participants will have a seamless and smooth experience. So first off, our today's presentation will be recorded and will be available for viewing on our website post-presentation. And if you have any questions for Terry during the presentation, please feel free to send me a chat directly. Once again, my name's Pauline. You should be able to find my name on the name list. And the chat function should be on the bottom section of your Zoom box. Lastly, if you're running into any technical issues, technical difficulties, please feel free to send me a message as well, and we will help you with that. So without further ado, my honor to present Terry Helton.
Good evening, I'm Terry Helton. I'm a registered nurse. I've worked for Livingston for about 12 years. I started as a hospice nurse and found even before that, when I worked in the hospitals and nursing homes, that I have a love for people who are approaching end of life and are at end of life. It just holds a special place in my heart. So naturally, it led me to want to be a hospice nurse and to do education based on end-of-life planning. And so tonight, it is my privilege to be able to speak for Livingston and as the chair of the Coalition for Compassionate Care for Ventura County. And I'm hoping that those who registered have a POLST copy. It will be easy tonight for you to look at that as we go through it. We won't be going through it immediately. We'll lead up to that, but I'm hoping you have that. I would like to review a little bit about the last few weeks that we had talked on the 5 Wishes, reminding us that the 5 Wishes is a form of an advanced healthcare directive where you're able to appoint an agent to speak for you if you cannot speak for yourself in terms of medical conditions, and that it allows you to put in writing what you want and don't want if you were unable to speak for yourself. So just a reminder on that. And that's important to know as we move into talking about continuing the conversation with the POLST. And go ahead and move next slide. So what is POLST? It's actually an acronym. We don't put periods between the letters, but it is an acronym for Physician Orders for Life-Sustaining Treatment. And the POLST has been around, next slide. The POLST is a physician or medical order that's recognized through the medical system. It has been around since 2009. The advanced healthcare directives have been since the early 1990s, but the POLST came about in California in 2008 through a law through the legislature, and it became available for use in 2009. And we think we're early, but Oregon did one in 1996. Not that that matters to us tonight. So the POLST is a portable document that transfers with the patient. It belongs to you. And of course, we talk about the 5 Wishes and advanced healthcare directive transferring with you also. But the POLST is an actual medical order and recognized by physicians, nurse practitioners, and physician assistants to be followed. And we're going to get a little more into that as we go forward. It is brightly colored, and we chose pink in California. Some states have a bright green. Some states have more than one page. We happen to choose the bright color of yellow because the bright color of pink because it is easily recognized. And if it's printed or you get the form from MedPass, it is a little more sturdy than a regular piece of paper. And if we can go to the next slide, it allows individuals to choose medical treatments they want to receive and identify those that they do not want. And it's very specific in this. It provides actual directions for healthcare providers during serious illness. PULSE complements the 5 wishes and other types of advanced healthcare directives. It is not necessarily a replacement. Remember, the 5 wishes allows you to designate a decision maker, an agent, or a surrogate decision maker if you are not able to make decisions for yourself. And it's important to know that that decision maker can have some responsibility if you're not able to make decisions for yourself to complete a PULSE or change your PULSE, make a new PULSE. So we will talk about that as we go along. Do know that both are legal documents. So the difference between a PULSE and the 5 wishes, and I could actually hold them up here and you can see there's a difference. But being serious, a PULSE for seriously ill or frail, it's not necessarily for people who are not towards the end of their life or frail in their illness. So I happen to be 68 years old. I'm very healthy. I don't have any real serious illnesses. And so a PULSE is not necessarily something I need. I'm not going to be surprised. My husband wouldn't be surprised if I were to die, he would be surprised if I were to die in a year or two. On the other hand, I have a friend who has a chronic illness and she struggles with that. I would not be surprised if she were to die in a year or two if she did not take care of herself in this chronic illness. And it would benefit her to have a PULSE because she is more frail at the age of 69 than a lot of people are at the age of 75. So that's a major difference. And also think about a 14-year-old, a 7-year-old, even a 3-year-old could be frail and seriously ill and may have a PULSE. Whereas an advanced healthcare directive is for anyone 18 years old and over. And an advanced healthcare directive must be signed by that decision maker themselves. It cannot be signed by a surrogate decision maker. So again, the PULSE is orders for a medical treatment, and the advanced healthcare directive is general instructions for treatment. And I described it in the past. If I were to collapse here and had an advanced healthcare directive that happened to be they know of, and I did not have a PULSE, the advanced healthcare directive to them would speak to what my wishes are. But the emergency people who are serving me would not be able to do what I want regarding not allowing to have CPR. They would not be able to do that, even though my advanced directive says I do not want CPR. So they would have to do CPR. However, if I were to collapse and I had a PULSE, they could find the PULSE on my phone that said, I do not want CPR, I want to allow a natural death. This would be a medical order that says, please do not allow CPR, and they would have to follow it. And I've already said that the PULSE can be signed by a decision maker, and advanced healthcare directive is only signed by the decision maker themselves, the person who is completing the advanced healthcare directive. So where does a PULSE fit in? Usually when we start these conversations, see the pink area there that says conversations. And I like to bring it back to that idea that even though this is a form, a document, the 5 wishes is a form and a document, it really is all dependent on having conversations with your family, your loved ones, your physicians, nurse practitioner, PA, whoever medically is involved in your life, and those who need to know. So these conversations ideally would start when you are younger, when you're 18 years old. I don't know if anybody's aware, but when a person gets a driver's license at 16 years old, they can designate what parts of their body they want to have donated for somebody else, or their tissues, and that does not take parental permission. And so at this age, we're already talking to them about these ideas. And so at age 18, they should be thinking about an advanced healthcare directive, and we should be having these conversations with them. And I find it interesting that we don't do that. I don't know how many of you watched This Is Us, but I watched it a little late, I guess, from when the episode occurred, but I watched the episode where she is sharing, the mother in this meets with her family and says, I want to have a talk with all of you they're out at their Thanksgiving site. And she pulls her 3 children and her husband together to have a conversation. And I'm sitting there amazed that she is entering into this idea. She who has been diagnosed with dementia still has her faculties about her and brings up this subject and brings it up in a very authoritative way of this is what I want and this is why I want it and I need you to understand this. And I thought that was a great conversation. Now that's the way that conversation would happen in that family. It may happen differently for other families, but it was so important that she started that conversation when she had the ability. And so going back to age 18 and even as our children are older teenagers, beginning to have those talks about the realities of life and the possibilities is important. So that's where we start. And we complete an advanced healthcare directive. And then when that 18-year-old goes off to service or college or gets married, another time to update that advanced healthcare directive. And maybe something happens in your own life, you have an advanced healthcare directive, and it's time to make changes in it. Maybe you're beginning some illnesses that are not conducive to where you want to go and what you're thinking about if you were to be hospitalized and need surgeries or need serious treatment. So it would begin to have more conversation. And it says diagnosed with serious or chronic progressive illness at any age. And again, I'm going to say it could be 3 years old, 7 years old, a teenager at any age, having that serious conversation with your medical provider. And as we're talking about these ideas of conversations about serious illness, it's going to your physician, that medical provider, and saying, well, I have been diagnosed with lupus. What does that mean for me? What's all of this about taking medication? What happens if I don't take the medication? What happens if I do take the medication? How long is this medication going to help me? What if this happens? Beginning to have not just one conversation with your medical provider, but a number of serious conversations, knowing the benefits and the problems associated with the treatments and the outcomes. Not one side, but both sides. Do the benefits outweigh the burdens? That's the question that you need to have. So having those conversations about serious illness, chronic diseases, might be a time to complete that POLST form. When you're deciding there are certain medical decisions you want to make for yourself and put them in a document, and where a document that must be followed by medical providers. And that would be completing a POLST form. And then knowing that your treatment wishes are going to be honored. So again, all of this comes back, before I move on, I have to enforce this idea of having conversations, having talks with your family, your friends, your medical providers, making this quote unquote a part of our lives.
Terry, before we move on to the next slide, we have a question. I have Kaiser Healthcare. Should this be something that should be on file with them after conversation with the doctor?
So this should be a series of conversations with your physician. Unfortunately, sometimes we have facilities that use the POLST form as a checkoff sheet. And that conversation needs to happen with that medical provider, your doctor in Kaiser or your nurse practitioner. And they should discuss each option. And we're going to go over these sections here pretty intimately. And at the end of that physician should be signing on this form. And if you are the person who's completing this pulse, then you shall also sign it, and we'll go over that at the end. And they should make a photocopy of this and keep it in your record. So briefly answering that question, and we will repeat that. So somebody is asking another question.
Yes, it seems like the pulse form would be of utmost importance in the event of a serious accident. Is that right?
So it's possible it could be of utmost importance, but say I'm a healthy 68-year-old and I'm driving and I have a serious accident and I'm not able to speak for myself. I'm hopefully going to have, great opportunity. I'm hopefully going to have in my wallet in my car and hopefully on my phone if it can be accessed, maybe one of these cards that we can send you that says advanced directive notification with my name and signature. And it says I have a healthcare power of attorney. I have an advanced directive. And it puts on here the name of the person I would like you to contact. So this can be very informative. But I'm not sure, at 68 years old, and my life could change, say, between now and 75. I have said I probably do not want to have CPR, but I would want full treatment. And if somebody doesn't know my wishes, they're going to pick me up and give me full treatment. And you're right, it would be interesting to have a pulse, but they would have to be able to have access to my phone, and I would have to have a pulse. And as we go into discussing this form, you'll understand why it's important that it is for chronically ill more than it is for those that are healthy. Is that a question for now?
I have one more question. What happens if your doctor will not sign the pulse form which you have completed?
Well, again, this should be why you should have a conversation with that doctor and help receive understanding from that physician why they're not wanting to work with you in what your decision process is. So again, it needs to be a conversation with that physician and what is their reasoning. And that physician should understand what your wishes are so that you come to an understanding. If you cannot communicate with a physician and have a conversation, then I'm wondering if maybe a different physician should be looked for. Because that's part of how our healthcare should go. It should be a conversation. It's not a physician dictating to you, but it's a conversation, a learning process for that physician to know who you are and understand you and look at your labs and the tests and how your body is working, how your mind is working, and what your values are to you, what matters to you. He or she should have that information, and you at the same time should be hearing what the physician is saying in regards to what would be best for your body, while also knowing what is best for you. So again, it's a conversation. This is not a black and white situation. This is always going to be a conversation. I hope that helps answer that question. And that actually leads us to this idea of who would benefit from a pulse. Somebody with chronic progressive illness. My brother with multiple sclerosis, who doesn't live in California and Alabama doesn't have pulse or any form like this, would benefit from this document to be able to put his wishes very, very accurately in writing. Those who have a serious health condition, somebody with cancer, that's a chronic illness, somebody with Alzheimer's disease, like the person in This Is Us, who at the beginning of her disease has her faculties about her and can fill this document out and have that conversation that we're talking about with her physician about what her wishes are, and then have her family understand. Again, the medically frail, and I didn't put it on here, but as we progress in age, I am able, and I could demonstrate, I'm 68 and I can get up and down from the chair easily. So I'm really not medically frail. I can walk up and down stairs and I can carry on, bend over, move things. crawled under my desk today because I lost my phone, that kind of thing. So I'm not medically frail, but as if I were to have a chronic illness or as I age into, I'm going to say my 90s, the likelihood that I become medically frail is there, and it would become difficult to get out of a chair that's somewhat medically frail. If I'm aging more, where I'm not able to walk well, where I'm requiring assistance to get up, I'm requiring assistance to just move with a walker, that's medically frail. And those are terms that we need to understand, is sometimes people are reluctant to complete documents, have these conversations because they think they can wait until they're sick. But again, it's back to that conversation and being able to do it in advance, being ready for it. So I encourage you to look at that. It's a tool for determination. Again, you wouldn't be surprised if this person died within the next year. You may know people that in your faith community. You may know people like that in groups that you meet in, that you wouldn't be surprised. And then you may know somebody down the block and now you see the ambulance down there and you wonder what's going on. You wouldn't be surprised. So how to talk to your doctor, how do I complete this post? Again, I'm going to bring it back to that conversation with your medical practitioner about what kind of medical treatment you would want if you became seriously ill, or if you are seriously ill. What are the benefits? What are the burdens? Talk to your nurse or doctor, nurse practitioner, physician about the post and how that would work for you, and again, about your family. I feel like I'm a broken record, but I cannot explain enough how important this conversation can be. I would like to, what do you hope to be able to enjoy for the rest of your life would be something to bring up with these medical practitioners. What do you like to do every day? Would it be a time to make these decisions that we're going to talk about? When you're not able to do those things every day, would it be a time to change your post if you had one? Are they relieved? Are the things that you're going to receive that the physician is ordering, are they going to relieve your burden of what you're doing for yourself, or are they going to add to them? I will say this, if completing an advance directive, completing a post, if you're edging towards your end of your life, will relieve a burden from your family. It is the loving thing to do. And it will relieve your family the burden of questioning what your choices would be. So this is the post. It's like the one I have here. And I don't know if we're able to move the cursor up to the corner where the circle is. That one. That is the EMSA. And it is the Emergency Medical Services Authority for California. This emblem is very important. I mentioned this document came into being by law, AB 3000 in 2008. That symbol is there because the emergency management system, the authority, will recognize the paramedics, the EMS will recognize this paper and know that they are supposed to follow what has been completed on here. I will say up front, if nothing is completed on here, and even if the doctor's signature is on here and there's nothing else that's been completed, they will have to provide full service. They will have to do CPR. They will have to take you to the hospital and provide full treatment. So that is the caveat that is written on the back of this form, and the instruction is there. So I wanted to say that up front. This form is not the first one. The first one was in 2009. It was a little brighter than this. It made photocopying hard, so that was the first change. And on the bottom of the page, I bring this up. It will give you the little numbers on the very bottom. You can see them. 2009, 2011, 2014, 2016. And what it says there is very important to understand. Any document of these polls that were completed at that time and have not been replaced with a newer post are still valid. So this does not have a deadline, an ending time. They are valid from the time they're created until they're void or a newer one replaces it. Is there a question?
Yes, the question is, if we travel out of state, what do we do? What states have this document?
Okay, so this post is made for California. New York has a mole, starts with an M like mother. It's 6 pages. But if somebody from New York were traveling here and they brought their molest with them and they ended up in the hospital or in a dire situation, the physicians there would recognize what those wishes were and hope to follow through with them. The same is reciprocal for California. If you were to travel with your post, or at least have it on your phone and it had a document of it, then medical providers would look at it and try to follow your wishes, is the understanding across the United States. It is not absolute, but in California, it is absolute. It is the law for California. Each state is developing their own form for the state some states haven't even initiated anything. California is part of the national post paradigm, and we are mature in our process. So I hope that answered that question. So we're going to move on to the section A, and it's very important that we look at this closely. And if you could take the cursor and go to the CPR, it says section A. And see, it says check 1, but over there it says cardiopulmonary resuscitation, CPR. And it says, if patient has no pulse and is not breathing, that's when CPR is initiated. So if a person does not have a pulse and is not breathing, then we would say they essentially have died. And what we want to do is resuscitate that. If the patient is not in cardiopulmonary arrest, then we're going to jump right to section B and C, but we need to talk about section A. So to attempt CPR resuscitation, then they have to have no heartbeat and no breathing. And so we would initiate CPR if that is what the person chooses. And I would also like you to see that in section A, if you choose CPR, in section B, the only choice you will have will be full treatment. Now, you'll also notice that it says do not attempt resuscitation, also known to many of us as a DNR, do not attempt resuscitation. In parentheses by that, it says allow a natural death. So if a person does not have a heartbeat and they're not breathing and we do not attempt resuscitation, then we are allowing a natural death. And that would be allowing us to allow them to die in peace, and it would be your choice. So if we choose to do not attempt resuscitation, we'll go to section B, and we'll turn the page, next slide. And this is section B. Notice it says full treatment, and it says at the very top of that, medical intervention if patient is found with a pulse and or breathing. So for example, suppose that I had experienced emphysema, and I'm going to use emphysema as a good example. I don't have emphysema, but if I did, and I collapsed, I was having difficulty breathing, and I was called 911. Somebody called 911 for me. They came and found me collapsed on the floor with this difficulty breathing and a rapid heart rate and just in distress. They would say, I have a pulse and I'm breathing, but you need to go to the emergency room. And in the emergency room, they're going to give me full treatment because that's what I've marked. And my primary goal of that would be prolonging life by all medically effective means. And so that would mean that I'm probably going to go into the ICU, and to give me some relief from my breathing, go on to a ventilator where the machine is going to breathe for me. And this is called intubation, and it's in that line there. And so it says, in addition to treatment described in selective treatment and comfort focused treatment, use in intubation, advanced airway interventions, mechanical ventilation and cardioversion, is indicated. So any of those things could be done for me in full treatment. And if I have emphysema, then it's probably going to be a use of intubation and mechanical ventilation for a period of time. So, and it also allows me, under there, it says a trial period for full treatment. And if I choose to have full treatment, then that full treatment, I can say I would only like a trial period of time. And as long as that is benefiting me and I'm getting better, that would probably be what I want. So that is the definition of full treatment. And full treatment is if you choose to have CPR, where you get CPR, then you're going to have full treatment. If you choose to not have CPR, and we're going to cover this in another slide, if you choose to not have CPR, but you still want full treatment, you have that choice, and you can allow to have a trial period of full treatment. Selective treatment is if you do not want to have CPR, you want to allow a natural death, and you choose selective treatment. And if I have emphysema, this may be a choice for me. A goal of treating medical conditions while avoiding burdensome measures. So that means that I'm not going to have ventilation in the ICU. I'm not going to go on a mechanical ventilator. I'm not going to have the respirator. I'm probably not going to have dialysis. But it does mean that I may have a BiPAP help me breathe, or a CPAP. It does mean that I could have IVs. It does mean that I would get antibiotics, just like I would get under full treatment. So, but I'm not going to get intubation. And generally, I'm going to avoid ICU care. Now, it says request transfer to hospital only, and that section is basically for people who are in skilled nursing facilities where they can give IV treatment and they can do BiPAPs, but if they're not being, the treatment is not being effective, they can be transferred to a hospital to receive a little more intensive treatment and possibly higher oxygen level rates for the care through the BiPAPs or just oxygen itself. So selective treatment is another area we can choose when we choose to allow a natural death. The next area is comfort focused treatment if I want to allow a natural death. And this primary goal of maximizing comfort. This is usually when somebody is not wanting to go back to the hospital. They're wanting to stay at home and get their comfort needs met. This is often when somebody goes on hospice. So are there questions pertaining to this area?
There are some questions, yes.
Let me go through the next one and then I'll answer those questions. Okay, so next slide. So here's a diagram of the medical interventions, and I'm going to go back to the story of the emphysema. So as you can see, there's an arrow, and if you can help me out there with the CPR, and it goes to full treatment, one arrow going to full treatment. If I get CPR, I get full treatment. If we go to the other side and we have the do not resuscitate to allow a natural death, I could choose full treatment, I could choose selective treatment, or I could choose comfort focused treatment. So I'm going to tell the story of what we can do. I have that emphysema, I'm in distress, they take me to the ER, I get to the ICU, they put me on a ventilator. They put a catheter in me for my urine. They put a line in for my heart to make sure it's running right. They put IVs in so I get fluid and IV treatment. And oh my gosh, now my kidneys may not be working right. So they're discussing dialysis. All of this is happening under full treatment. Oh, phew, I don't have to have dialysis. And so I soon recover from with the antibiotics and the help of the ventilator treatments and the breathing treatments. And I meet with the chaplain from the hospital before I go home, and we discuss things, and I say, I never want to do this again. I don't want to go back to the ICU. And she says, so do you want to do a new pulse? And I say, yes, I do want a new pulse. I still don't want CPR. I don't want anybody pushing on my chest, breaking my ribs. I really don't want to do that, but I really don't want to go to the ICU again. And she says, well, you don't have to have CPR, but you could have selective treatment. So we draw a line through my old post, we void it with the date, we get a new post, and I fill it out, allow a natural death, and I choose selective treatment, and then we'll go through the rest of this. The doctor signs it, I sign it, and I have a new post. And lo and behold, in about a year, I'm sick again, and the paramedics come and they take me to the hospital, and in the ER, they read my pulse that has gone with me, and they say, oh, you don't want to have CPR and you don't want to have full treatment. And I said, that's right, I never want to go there again. And so they say, well, we still want to admit you, and we're going to admit you to such and such a floor. And they help me with BiPAP treatments and IV antibiotics and breathing treatments, and I get better. I do this about 3 times in a couple of years, and I go, I'm so tired of this. I don't want to do it anymore. I really, really don't. And my emphysema tests are so bad. And so I meet with my physician, my pulmonologist, respiratory doctor, and I say, you know what, we need to talk about this. And so my doctor hears me, is talking with me. We talk about my labs, my choices, what I want, what I don't want. And we void this old post, date it, put a new post, and I fill out, allow a natural death. I choose comfort-focused treatment. We finished the discussion on the post and the options for hospice care probably, because I don't want to do this anymore. And then he signs the document, I sign the document, and we're good to go. That's how that works. Are there any questions on this part, Nat?
Yes, actually, the first question is related to what you just talked about is, I have a post that I filled out after my wife passed away 5 years ago, but it is not signed by my doctor. So will it be followed?
It will not. It is not a valid order. An order, and the post is a medical order. Just like if you were in the hospital and the doctor were writing an order for treatment, the post is a medical order, and it has to be signed by either a physician, a nurse practitioner, or a physician assistant. And it must be dated. And therefore, your post is not a valid document.
The next question is, if a pulse is in my record or chart and I have surgery and I go into cardiac arrest, will this document be valid and followed?
If you are in surgery, this document will not be followed because of and I can't say what the statutes are, but I know that anytime you are in surgery and you give consent, their full means is they want to revive you and bring you back to life during that time. Now, I've talked about when I did the 5 wishes that I was going to have shoulder surgery at the time, and I did not want to end up in a long-term facility on a ventilator. And that's what scared me into doing my first advanced healthcare directive. So that would be true for the post. If you survived that surgery and you came out, then that post should cover the effect after the surgery, that they should not be resuscitating you. Or they should be following what the post says at that time.
So following that question, do you need to be consistent with your decisions in the 5 wishes and the pulse?
Yes, you should be consistent with your wishes in the 5. They should complement each other. There should not be a disagreement between the post and your advanced healthcare directive or the 5 wishes. They should be a complement. So if you put in your 5 wishes that you do not want to have resuscitation, then that is what you should have on your post. If you put in the 5 wishes that you would like to have CPR, then you should put on your post that you would like to have CPR. Now, saying that, if you want to change your mind about something, then you should do a new document so that they are current with each other. Does that make sense? Okay.
That's all the questions that we have for now, Terry.
Okay, so we're going to go to section C. And section C is a very difficult discussion for a lot of people. It says artificially administered nutrition, and further on that gray area, it says offer food by mouth if feasible and desired. So it's important to know that regardless of our situation, you can choose to have food offered by mouth, and if you want it. And sometimes towards the end of life, this is all that people want, and they want to avoid these other things we're going to talk about. So pleasure comes from the flavor, pleasure comes from the texture sometimes, or the socialization. That is something important to remember. And it's also important to remember as people approach end of life that their desire to eat leaves. Some of the things they liked in the past, they don't like anymore, and they have new desires. But generally, as people are approaching end of life, they have a hard time with eating. So we're going to talk about the long-term artificial nutrition first, including feeding tubes. And this is when somebody has, actually, I'm going to turn this around. I apologize. I'm going to start with the trial period, which is actually in the middle, to give you some understanding. If I happen to be in a car accident and I go into the hospital and I'm not conscious, and I don't happen to have 5 wishes, an advance directive that they can look at, and I end up in this hospital from this accident, and I'm on a ventilator, they're going to put in a feeding tube into my nose that goes down my nose, down my throat, down my esophagus, and into my stomach to give me some artificial nutrition. And that would be to help my body fight and recover while I'm on that ventilator and recover through my body. So that's generally a purpose of temporary trial period of artificial nutrition. And that is something that physicians don't want to leave in longer than about 2 weeks. And if it's going to stay in longer than 2 weeks, their suggestion is going to do a long-term artificial nutrition, which is what that first one blank is. And then they go in and they do a surgery to put a tube into the stomach, and it goes through the different layers in our abdomen to the stomach, and it's anchored in. And so those are 2 ways of receiving artificial nutrition. So that is often people think about starving and the problem with not having food. There's a discomfort with not eating. And as we age and as our bodies are approaching end of life, our bodies don't want as much food. They can't handle as much food. And when we're approaching that end of life, we can actually cause food, nutrition to be a burden on our body because our intestines, our stomach, the different organs involved in nutrition have difficulty with it, and it causes more stress on the body than not eating. That's why people who are approaching end of life don't eat so much. And I remember with my brother-in-law, it was like, everybody wanted him to eat, and he really didn't want to eat, just one more bite. And he really, really didn't want to eat. And it's nothing personal. It was just his body was saying enough is enough. So that's something to determine when somebody has a chronic, serious illness. The other thing is to think about the chronic serious illness of dementia as people age or they have a stroke and their brain is losing the ability to have their throat help them swallow. They lose that ability to swallow with dementia or possibly with a very severe stroke like my dad had. Then the feeding tube going into their stomach will bypass that, but they will also have trouble swallowing their saliva. And that is very likely to go into their lungs and cause problems with pneumonia. And when a person, and studies have shown, when a person has a long-term feeding tube, they are still likely to get pneumonia. They are still likely to waste away and have other complications. And they're more likely to have problems with pressure ulcers and wounds, and the discomfort of the tubes themselves. I cared for a couple of patients who were able to communicate with me. They had ALS and they communicate in other ways. And they actually told me that long-term feeding tube in their stomach caused them discomfort. So I like to be honest about that. But on the other hand, if it's a temporary situation, that feeding tube could be very beneficial. So again, I'm going to bring it back to that conversation idea with your medical provider. Very honest conversations about the benefits and the burdens of it, what it would mean for you if you had a chronic disease where this was a temporary measure, what it would mean for you if you have a chronic disease and this is a long-term measure. Would it benefit you? Would it allow you another year to be with your child and see them married or see your grandson graduate? Those are very important questions that matter. What matters most to you and what are your values? But it's also fair to know the burdens and the benefits. Do we have questions on this?
There was a question that came up asking what is 5 wishes that we mentioned. Is it a form? Does it include 5 forms? I am unclear. I went ahead and sent them the information about the session that we recently hosted.
Okay, that's great. So we're going to look at section D on this, and it's the information and signatures. And I had to take, the other ones were from a form that worked really well, and I had to grab this from a newer form because the one I was using did not have the most important update that came along in 2016 on it. And what it says is discussed with patient, and this patient has capacity, and that is on this form, if you'll see that there. And there's a checkbox for that. And then another box right next to it says legally recognized decision maker. So that would be for the person that you have on your advanced healthcare directive that you've appointed as an agent, could be that decision maker if you are no longer to decide for yourself. So that is what the doctor is going to click off. And then it says advanced directive and the date on that if it's available. And notice it says available and reviewed. Healthcare agent, if named in advanced directive, there's a place for the name on there and the phone number of that decision maker. Under there's advanced directive not available, meaning they didn't have it when they filled out this form and they would like you to bring it and match it up if possible. Or there is no advanced healthcare directive. You can see that right there. So that's very important information to know. The next section, as you see, says signature of physician, nurse practitioner, physician assistant. And that doesn't mean you need all 3 signatures. It just means you need one of those signatures with their phone number and with their license number. All of those are needed. And of course, the physician's name needs to be able to spelled out, or the nurse practitioner or the PA needs to be able to be readable so that it can be traced if possible. Saying that, if I'll say a physician in this case signs this document and then they die, the document is still good. It does not void their signature. The other important thing by that signature is the date. So the date is very, very important on this document, just as it is on the advanced healthcare directive. And then signature of the patient or the legally recognized decision maker. As I said to that gentleman, this or that person, this is a void document. They're going to have to do full treatment unless this signature is here, this medical provider signature. It is also not a valid document unless the decision maker, yourself or the decision maker for you, has printed and signed their name and put the date in here. So that's just as important. And then I'm going to take a second. There's a corner here that says your post may be added to a secure electronic registry to be accessible by healthcare providers as permitted by HIPAA. And this is a HIPAA valid, meaning that it can be shared between medical entities such as a hospital, hospice, nursing facility. These can be shared, the EMS, so that this is a HIPAA verified document, so it can be shared. And our hope is that there will be an electronic post registry in Ventura County. So this will not only be a paper document, but it will be able to be turned into an electronic document. So there is one other thing, and I don't think you can see it on here, but if you can see it in the post, if you have it in your hand, it says right under signature of the patient or legally recognized decision maker, I am aware that this form is voluntary. This is not a form that can be pushed on you. So if you happen to go to a skilled nursing facility for rehab, they cannot insist that you fill out a POLST form, and it is actually against the law. It would be a good thing to have a POLST form, but it is not something that they can absolutely make you do. So I'd like you to know that. Next slide. So surrogate decision maker, who can speak for the patient? I talked about the surrogate decision maker, the agent, the one that we hope you have put into your new or updated advanced healthcare directive. A parent, a registered domestic partner, a guardian, a conservator can speak for the person if they cannot speak for themselves. A parent could have a POLST form for a 3-year-old that has cancer, or say a 14-year-old who has cystic fibrosis, and that cystic fibrosis, person with cystic fibrosis is saying they're exhausted, they're tired, they really don't want to do this, they don't want to have CPR. Could have that conversation with their parent and their pediatrician, and the parent could make that decision to have a POLST for that child. So that's how we talk about this. Somebody with developmental disabilities, a guardian, a conservator could do, or even the person with the developmental disability, if they have that capacity and the physicians determine that, could have a POLST if they are if they're not chronically ill, but they feel like they need one. And one of the reasons I bring that up is that sometimes a person with developmental disabilities will end up in the ER, and the people who are in the ERs have compassionate, loving hearts, but they don't always think the way that parents, loved ones, people think about that person with disabilities, and they may suggest, well, this is your opportunity to allow that pneumonia to allow them a natural death. And that's not what the parent, the loved one, wants. And so a POLST can save that pain for people also. If there is no person, registered domestic partner, spouse, a guardian, a conservator around to make those decisions, then a physician will choose the one who has been closest to the person who is facing their end-of-life crisis. And finally, where do I keep a POLST? The original pink POLST belongs to you. It is your property. If you fill it out in a hospital or a nursing home, it should go home with you, the original pink one, not a copy. The physician should not keep the original. He or she should make a photocopy. Photocopies belong to the hospital, the nursing home, the physician's office, whomever, your agents, your family members. The bright pink one belongs to you. And the best thing you can do is to take it home, post it in an easy to find location with your advanced healthcare directive. This happens to be the 5 wishes. This happens to be, I put it in the wrong direction, my POLST or the POLST, and notice they're together. And I would also suggest that you put in a copy of your medications and your a simple medical history, and then you can tape this to the side of your refrigerator. You could put it by your bed. You could put it near your medicine cabinet, someplace where it's easily seen. The other thing is that you should be able to give a copy to all of your loved ones. It should be in a record in the hospital that you're going to possibly be in, and it should be a record with your medical provider. So I think the last one, can a POLST be changed? We talked about that. Yes, it definitely can be changed. And then finally, the last thing is the back of the POLST is an area to put, for instance, if I went to meet with you special, I could put my name back there as somebody who's helped you with this. And if they wanted to clarify any of my conversation, then they could contact me. It is not necessary to fill that second part out, especially if this is a conversation you've had with a physician or a nurse practitioner or PA. However, it is important that if photocopies are made of this, that both sides of the polls be copied so that people understand that the directions that are listed there, it says directions for healthcare providers, so that the healthcare provider can read it and understand this document. And I think that's an important part of this. Now, are there more questions I can answer?
Yes, I believe you briefly answered the first question, which is, after I fill this out, should I take it to the local hospitals? Will they add it to my records?
If you fill this out and the one of those medical entities, a nurse or nurse practitioner, a PA or a physician have signed it, and you have signed it, then, and dated it, yes, they will be glad to have it in their records.
The next couple of questions are regarding the electronic registration. First one is, how do I support the electronic registration? The second one is, how do we go about getting a pulse in an electronic registry?
We've been, as the chair of the Ventura County Coalition for Compassionate Care, I think we've been working on this for 4 or 5 years. And you could allow your local EMS person to know that this is something you want and that it's valuable. You could write the state EMS person and allow them to know that this is something you really want in Ventura County and you would like to see. And I have to tell you, Governor Newsom signed a law into being last year for $10 million to have electronic pulse registries be coordinated through the state of California. There have been 2, one in Contra Costa County that was not totally successful, one in San Diego area that was not successful. There is the one in Ventura County that is ready to pop if we can get the hospitals to work with us, and that's the financial being. And there's one in San Gabriel area, San Bernardino area that is ready. And so I will tell you that the head of EMS for California, a representative from the California EMSA, is coming this next week to talk to the person who is pushing this electronic pulse registry. I will only be on a phone call with them. And we're hoping to make that the first actual viable step to see it happen. So there is money behind this in the state. It is really going to happen. It's just, we need your support in doing this. So if I tell Linda that we are ready to start putting people's names in this registry, she can email you and let you know how to register for that. And that electronic pulse registry that we're hopeful for will be able to have the person, the patient will say, put in their information, register, and be able to sign electronically. And hopefully the physician will be able to register and go in and see your name and register and sign electronically and be able to keep a conversation going. So I've seen this work. It is safe and secure. There's been a lot of effort put in to protect people's names and information. And it's just waiting. It's like a horse race. They're ready at the gate. So it is a very viable thing.
There we have a few questions that came up. First one is, if I have an advanced healthcare directive, do I really need a pulse?
Okay, so we're going to go back to that idea of chronic illness and the possibility of you being found at home on the floor if you have a severe chronic illness and you would not do well in the next couple of years. My suggestion is, yes, you need a pulse because it's a medical order. It is not just suggestions. Where an advanced directive allows for a decision maker, the pulse allows for your medical wishes to be definitely followed because it's a medical order.
Does Livingston have a doctor that would go over this with me, sign it, or is your doctor, nurse practitioner, or physician assistant the only one that can sign it?
If you, I will say that if you were on hospice, then we do have a physician that would be willing to sign to post. If you are being seen by one of these other, and many people as we age, I happen to be seen by 2 doctors at this point, well, 3, I guess, if you count the eye doctors, ophthalmologists. I have 3 physicians, and it's not surprising as we age that we accumulate specialists. And so any of those physicians could sign the post form. It is best to have this conversation with your primary care physician, though. But you could have this conversation with any of those physicians, and they could sign the document.
The last question that we have is, why did the registry fail in those 2 counties you mentioned earlier?
Why did the electronic post? Well, they had, it was very complicated. They were putting it on a paper post and filling it in to an electronic source in a more difficult way. It did not allow for the patient to have access to it after it was completed. So you would have to replace the electronic post that they had with another paper document, so to speak. And the post that we're hoping to see happen can be done electronically. So if a patient changed their mind, they're registered and they change their mind, they can go in and make that notification that will ping the physician who had signed it, so they can go in and have that conversation and do it. You could also do it in the same room. Both of you are having that conversation and do it electronically. So the hope is to take the paper form that we have now. We can still use the paper form even as a paper document and be able to scan it and put it into the electronic post also. So it can happen both by typing it in, and it can happen by scanning it in. And the electronic post that is waiting at that gate will be able to do different languages. It's already being set for multiple languages. So the one in San Diego was successful within a that healthcare entity. So say we have Dignity Health in this county, it would work between Pleasant Valley and St. John's. And that medical entity in San Diego, it was working between that hospital and a nursing home, but it wasn't for the larger community. It wasn't looking viable. So does that answer that question well? Yes, my heart is there and I'm hopeful, so thank you.
If you have any additional questions, please feel free to type them in the chat box. We will post all additional questions and answers on our website with the recorded presentation. Once again, I want to thank everyone for attending and for supporting Livingston. We're a resource to you. Linda, I know a few people also requested copies of the 5 Wishes booklet. Linda and James are sending the link right now to register for your request. So just keep an eye out for that.
I do want to say something. If you are, Pauline mentioned there might be a couple of people here from local agencies. And if you are in touch with any of the hospital CEOs, COOs, CFOs, you would let them know that the viability of this could actually in the long run be a wonderful thing. So that personally is a great idea.
Thank you, everyone. Have a good evening.
Thank you so much, guys. Appreciate your help.
Thank you. Bye-bye.
Take care.
I'm going to make that sales pitch.